Welcome to the Hospital Medicine Unplugged podcast, where we perform a rigorous deep dive into the management of high-risk, common conditions encountered in inpatient medicine. Our focus today is on metabolic alkalosis.
Right, and this is, well, arguably the most pervasive acid-base challenge we face in the hospital setting. You know, acidosis often gets more attention, but if you look at the retrospective data, metabolic alkalosis consistently comes out as the most common disorder.
Especially in critical care, right?
Exactly, particularly among the critically ill. And often, it's something we cause, or at least contribute to.
You mean iatrogenically?
Yeah, frequently it's a direct consequence of the therapies we're using, think high-dose loop diuretics or aggressive volume loading, sometimes massive blood product administration too.
Okay, so let's just pin down the definition first. We're talking about a primary elevation of serum bicarbonate, the HCO₃.
Correct. And along with that, an increased arterial pH.
And the body tries to compensate how?
Through hypoventilation. It's the body's natural attempt to retain sucrose, so the partial pressure of carbon dioxide, the Pco, goes up to try and balance the pH.
And you mentioned the prevalence. It's not rare.
Not at all. It's startlingly common, actually, for something we might just glance over on the labs. Retrospective analyses, particularly looking at ICU patients, have shown that maybe up to 29% of admitted patients can have a serum bicarb concentration over 30.
29%. That's almost a third of ICU patients.
Yeah. And in general, surgical patients looking postoperatively, that number might be even higher, potentially up to 50% in some series. It's really a fundamental issue in inpatient care.
And crucially, this isn't just an academic point or a number on a lab report.
Absolutely not. While, mild alkalosis might not cause obvious symptoms, the clinical threat really scales dramatically with the severity.
So there's a threshold we worry about.
Definitely. When that arterial pH climbs above 7.55, that's when we consider it severe alkalosis. And that level of elevation is strongly and independently associated with a significant jump in both morbidity and mortality.
Okay, let's talk about those complications. What should we be most concerned about?
Well, the list is pretty systemic, and it warrants immediate attention. I think cardiologists worry first about arrhythmias.
Right, the cardiac effects.
Yeah, there's an increased risk of complex arrhythmias, especially if the patient already has underlying heart disease or other electrolyte issues happening at the same time, like hypokalemia or hypomagnesemia. The alkalemia itself messes with ion channel stability.
And the effect on calcium is critical too, isn't it?
Vitally important. Alkalosis makes calcium bind more tightly to albumin,
which lowers the free ionized calcium.
Exactly, and that's the biologically active fraction. So you get this drop in ionized calcium, which can manifest as significant neuromuscular irritability.
It's like what specifically?
Paresthesias, tingling, muscle cramps, even frank tetany or seizures in severe cases. For our colleagues in the neuro ICU, that's a really dangerous complication to miss.
Yeah, absolutely.
But maybe the most frequent clinical headache, especially in the ICU, comes from the pulmonary effects.
How so?
Well, severe alkalosis shifts the oxyhemoglobin dissociation curve to the left.
Meaning hemoglobin holds on to oxygen more tightly?
Precisely. So it actually impairs tissue oxygen delivery, which seems counterintuitive, but it's critical. And perhaps most frustratingly for intensivists, it suppresses the central respiratory drive.
Making it harder to wean from the ventilator.
Extremely difficult. The evidence here is pretty robust. Both the duration and the severity, the magnitude of the alkalosis independently predict longer ICU stays and, unfortunately, higher hospital mortality. It can quickly go from just being a physiological finding to actually driving poor outcomes.
Okay, so that really underscores the need for prompt recognition and targeted action. But before we jump into treatments, we really need to understand the underlying physiology, right? This core principle you mentioned.
Exactly. The idea that metabolic alkalosis needs two distinct things to happen and persist.
Two processes.
Yes. First, you need the generation of excess bicarbonate, or alternatively, the loss of acid. That's step one. And second, you need impaired renal excretion of that excess bicarbonate. That's the maintenance phase. Without that second part, the kidney would usually just fix it.
So the kidney's failure to correct is key.
It's the most important concept for hospitalists, I think. A healthy kidney is incredibly good at handling excess bicarbonate. It can dump huge amounts if needed. So if you see persistent metabolic alkalosis, you know the kidney isn't doing its job correctly, often because of factors we're influencing.
Okay, let's break down the generation phase first. You said acid loss or alkali gain.
Right. The classic example of acid loss is from the GI tract. Think high-volume vomiting or continuous NG suction.
Losing stomach acid, HCl.
Exactly. You're losing massive amounts of hydrochloric acid.
Yeah.
Physiologically, losing that H+ ion is the same as gaining a bicarbonate ion. So that drives the alkalosis.
And what about the kidneys contributing to acid loss?
Well, often we drive that with diuretics. Both loop and thiazide diuretics increase sodium and water delivery down to the distal tubule.
Okay.
This increased flow stimulates potassium secretion, but also hydrogen ion secretion, particularly via the intercalated cells. And every hydrogen ion secreted out means a new bicarbonate ion is generated and reabsorbed back into the blood. So the diuretic itself generates bicarbonate.
Is there a difference between loops and thiazides here?
Yeah, it's an interesting point. Loop diuretics, acting on the thick ascending limb, tend to cause more significant volume loss and often more pronounced hypokalemia. This leads to a greater secondary hyperaldosteronism response, which then fuels both the generation and the maintenance of the alkalosis, probably more forcefully than thiazides usually do.
Okay, that makes sense. And the other side of generation was net alkali gain.
Right. This happens when we give substances that get metabolized into bicarbonate. The most obvious is giving sodium bicarbonate itself, maybe to treat acidosis.
Sure.
Less obvious, but important in the hospital, are things like large volumes of citrate, which is in blood products used for massive transfusion protocols.
Ah, the anticoagulant.
Exactly. Or lactate, which is in some resuscitation fluids like lactated ringers. Both citrate and lactate get metabolized by the liver into bicarbonate. This can create a transient, but sometimes quite significant, alkali load.
But you stress that this generation phase is often temporary unless the kidney fails to correct it?
Precisely.
Yeah.
Which brings us to the maintenance factors, the reasons the kidney can't excrete the excess HCO₃. And frankly, these are usually what we target with our treatments.
So what are the main maintenance factors?
The single most common one we see, especially in hospitalized patients, is volume contraction, or effective circulating volume depletion.
Even if the patient isn't obviously dehydrated.
Yes, think heart failure or cirrhosis, where the effective volume is low. The kidney senses this, activates the renin-angiotensin-aldosterone system, or AAS.
Okay.
And angiotensin II is a key player here. It strongly stimulates sodium reabsorption in the proximal tubule, but it also stimulates bicarbonate reabsorption right along with it. The kidney is just desperately trying to hang on to volume, and bicarbonate gets reabsorbed as part of that process, preventing its excretion.
And this is where potassium and chloride come in.
Yes, it gets intricate here. Hypokalemia makes the alkalosis much worse. It really perpetuates it.
Oh.
Well, low serum potassium causes potassium to shift out of cells. And to maintain electroneutrality, hydrogen ions shift into the cells. This creates an intracellular acidosis within the renal tubule cells. And that intracellular acidosis is a powerful stimulus for those cells to secrete more hydrogen ions out into the urine and produce more ammonium. Both of those processes generate new bicarbonate that gets reabsorbed because of a vicious cycle.
Wow, okay. And chloride's role?
Hypochloremia is almost always part of the picture in volume depletion, especially from vomiting or diuretics where you lose chloride disproportionately. Chloride is absolutely essential for bicarbonate secretion in the collecting duct. There's an anion exchanger there called pendrin.
Pendrin, okay.
It swaps chloride coming in for bicarbonate going out into the urine. If the chloride level in the tubular fluid is low, pendrin activity is impaired. So if you can't secrete the bicarbonate, you end up retaining it. Chloride deficiency directly maintains the alkalosis.
That's a really key point.
It is. And then finally, we have states of aldosterone excess.
Like Conn syndrome.
Right, that's primary hyperaldosteronism, or it could be secondary hyperaldosteronism driven by things like heart failure, cirrhosis, or even just persistent volume depletion. High aldosterone levels stimulate sodium reabsorption in the collecting duct through the E&C channel. This makes the lumen electrically negative.
Which drives secretion of positive ions.
Exactly. It enhances secretion of both hydrogen ions and potassium ions. This sustained distal mechanism keeps bicarbonate reabsorption going strong, maintaining the alkalosis. And of course, just having a reduced GFR, reduced kidney function overall, acts as a simple mechanical limit. Less bicarbonate gets filtered, so less can be excreted.
So this whole physiological picture really shows that our management has to zero in on which of these maintenance factors are actually in play for a given patient.
Absolutely. And for the busy hospitalist, that means we need more than just the serum electrolytes. We need a specific diagnostic approach.
Which brings us, I think, to the diagnostic triage you mentioned earlier.
Yes. We start, obviously, with the arterial blood gas to confirm the metabolic alkalosis. Then we look closely at the serum electrolytes. Potassium and chloride are key. But the real game changer, the essential test that dictates our management strategy, is the spot urine chloride measurement.
Why is that one test so critical?
It's often overlooked, honestly, but it immediately helps us divide patients into two main categories that need very different treatments. It tells us if the alkalosis is primarily driven by volume and chloride deficits, what we call saline responsive, or if it's resistant to simple saline therapy, meaning saline resistant.
Okay, let's tackle the first one. Chloride-responsive metabolic alkalosis. This is the one fixed by salt water, right?
Pretty much, yeah. It's inherently linked to volume depletion.
And what's the urine chloride finding here?
Consistently low, typically less than 20, maybe less than 25 millimoles per liter.
And the causes?
The classic ones are GI acid loss, so active vomiting, NG suction, or, and this is important, remote diuretic use.
Remote, meaning not right now.
Exactly. The patient took the diuretic, maybe yesterday, lost volume and chloride, and now the direct effect of the drug has worn off. But the volume depletion persists and is now driving intense renal conservation.
And the physiology behind that low urine chloride?
It's the kidney's appropriate response to perceived hypovolemia. It ramps up sodium and chloride reabsorption, mostly in the proximal tubule, trying desperately to hold on to fluid. Because it's reabsorbing nearly all the filtered chloride, very little makes it into the final urine. Hence, the low urine chloride value.
So clinical clues would be?
Signs of hypovolemia on exam, maybe orthostasis, dry mucous membranes, perhaps a low CVP if measured. And usually hypokalemia is present too. That low urine chloride is basically the kidney yelling, "I need chloride in volume." This is definitely the most common type we treat in the hospital.
Okay. Now contrast that with the chloride-resistant or saline-resistant type. This sounds like a different beast altogether.
It is. It often points towards a primary tubular problem or a hormonal issue.
And the urine chloride here.
It's high. Typically greater than 20, often greater than 40 millimoles per liter.
So the kidney is losing chloride in the urine despite the alkalosis.
Exactly. That high urine chloride tells you that even though the patient is alkalotic and maybe even volume depleted, the kidney is still inappropriately dumping chloride. Saline won't fix this because the problem isn't just volume or chloride deficit.
What causes this type?
The main categories are states of mineralocorticoid excess, like primary hyperaldosteronism, Conn's syndrome, or, less commonly but important to remember, things like ongoing high-dose diuretic use where the drug effect is still active. Severe persistent hypokalemia itself can cause it. Or some inherited kidney tubule disorders like Bartter or Gittleman syndromes.
So the underlying issue is abnormal kidney function or hormonal drive.
In primary hyperaldosteronism, the aldosterone level is inappropriately high, constantly driving sodium uptake and potassium hydrogen wasting regardless of the patient's volume status. These patients might be euvolemic or even look hypervolemic. And because the kidney's chloride handling is being overridden by that hormonal drive, giving them saline is useless for the alkalosis and might just worsen their volume overload or hypertension.
So clinical clues for this resistant form might be hypertension?
Often hypertension, especially with primary hyperaldosteronism, also persistent, often quite severe, hypokalemia. And as I said, a relatively normal or even high volume status on exam.
How do you differentiate ongoing diuretic use from, say, cons?
It can be tricky. Hypertension strongly points towards primary hyperaldosteronism. If the patient has known severe heart failure or cirrhosis and is on high-dose diuretics, that suggests secondary hyperaldosteronism driving it, but it still falls into the resistant category if the diuretic effect is ongoing and they're losing chloride. Making this distinction based on the urine chloride and clinical picture is absolutely foundational for picking the right treatment.
Okay, that makes sense. Let's move into management then. The general principle is fix the cause and reverse those maintenance factors we talked about.
Exactly. Address the underlying etiology and aggressively correct the volume, potassium, and chloride deficits.
So for chloride-responsive alkalosis, the low urine chloride kind, what's the mainstay?
It's physiologically quite elegant, actually, and usually very effective. Volume repletion with isotonic saline, 0.9% sodium chloride.
Just saline.
Well, crucially, saline plus aggressive potassium chloride replacement. KCl is key.
Why both components?
Because you're hitting all three major maintenance factors simultaneously. The saline corrects the volume contraction, which removes that angiotensin, the second stimulus, for proximal bicarb reabsorption. Providing the chloride gives the collecting duct the anion it needs, via pendrin, to finally start secreting the excess bicarbonate. And replacing potassium as KCl corrects the hypokalemia, which stops that cycle of intracellular acidosis, driving more hydrogen secretion and new bicarb generation. You're giving the kidney back the tools it needs to fix the problem itself.
Okay. Any practical tips on the potassium part?
Yes, prioritize it, and don't be timid with dosing. If the serum potassium is low, say less than 3.5 millimole, you often need significant amounts, maybe 60 to 120 millimoles per day, or even more, depending on the deficit. And it must be given as potassium chloride, KCl, not potassium phosphate or acetate, because the chloride anion is just as therapeutically important here as the potassium cation for correcting the alkalosis.
Good point. Are there situations where standard saline is risky?
Yes, definitely. Patients at high risk for volume overload, think severe CHF exacerbation or underlying kidney disease, giving lots of normal saline could easily cause pulmonary edema.
So what do you do then?
It's a bit more nuanced. We still need to deliver chloride, but without the large sodium load. In these specific high-risk cases, alternative chloride-rich solutions have been considered. For instance, there are formulations like high cation gap amino acid infusions. They provide a good amount of chloride, but relatively less sodium compared to normal saline. This might help replenish chloride stores while minimizing the sodium overload risk. But it's definitely a more specialized approach for select volume-sensitive patients.
Okay, now shifting gears to chloride-resistant alkalosis, the high urine chloride type, you said saline is ineffective here.
Right. Not only ineffective, but potentially harmful if the patient is already euvolemic or hypervolemic. It can worsen their volume status or blood pressure.
So the focus shifts entirely.
Completely. You have to treat the underlying root cause, the hormonal or tubular defect. If you've diagnosed mineralocorticoid excess, like primary hypoaldosteronism, the treatment is an aldosterone antagonist.
Like spironolactone.
Exactly. Spironolactone or sometimes eplerenone. Plus, you still need aggressive potassium repletion, often with KCl. Spironolactone directly blocks aldosterone's effect in the collecting duct. It reduces that distal secretion of hydrogen and potassium ions, which breaks the cycle that generates new bicarbonate.
What about those inherited disorders, Bartter or Gittleman?
Those are essentially genetic salt-wasting conditions in the kidney tubules. Management there is really about long-term, targeted replacement of the specific electrolytes they consistently lose. This often involves very high doses of potassium, magnesium supplements, and sometimes for Bartter syndrome, maybe NSAIDs if appropriate, though that's more specialized outpatient management. The key for a hospitalist is just to consider these syndromes if you encounter persistent, unexplained saline-resistant alkalosis, especially in a younger normotensive patient.
Okay. Now what about the really severe or refractory cases? When the pH is dangerously high or the patient is very symptomatic?
Right, these are the situations where the arterial pH is, say, above 7.55, or if the patient has clear clinical consequences, maybe dangerous arrhythmias, refractory hypokalemia causing weakness, seizures, or probably most commonly, respiratory failure due to that suppressed drive.
Ventilator weaning issues again?
Exactly. These are life-threatening scenarios that demand more aggressive, sometimes centralized interventions to bring the pH down more quickly.
What's the first-line agent for that?
Often, it's the carbonic anhydrase inhibitor, acetazolamide, as A2-HL-umide.
How does acetazolamide work?
Its mechanism is nicely targeted. It inhibits the carbonic anhydrase enzyme, mainly in the proximal tubule. This enzyme is crucial for reabsorbing filtered bicarbonate. So by inhibiting it, acetazolamide forces the kidney to excrete bicarbonate in the urine, essentially inducing a bicarbonate leak.
What's a typical dose?
Standard starting dose is often around 250 to 500 milligrams to feed, maybe every 6 to 12 hours. But you absolutely have to adjust based on renal function.
When is it most useful?
Its main niche is probably in the patient who is clearly volume overloaded, like bad CHF or decompensated cirrhosis, so ROHTs, with ascites, CHTs, where giving saline is strictly contraindicated, but you need to correct the alkalosis.
But you mentioned evidence interpretation is key here.
Yes, the evidence base for acetazolamide needs a very careful look. Meta-analyses and some RCTs, especially those looking at patients with respiratory failure, complicated by metabolic alkalosis.
Like the COPD patients we discussed.
Right. They show acetazolamide does effectively and rapidly improve the blood gas numbers. It lowers the pH, lowers the bicarbonate, and usually allows the PCO to rise a bit. And there's some data, suggestive perhaps, that it might reduce the duration of mechanical ventilation in some cases.
But there's a but coming.
There is. The critical caveat for us as practitioners is that it has consistently failed to show a clear mortality benefit in these settings.
Yeah, so it fixes the numbers, but maybe not the patient outcome.
That's the ongoing debate. Are we just treating a lab value without fundamentally changing the course of the critical illness? Plus, the trials do show that adverse events are more frequent with acetazolamide. Things like electrolyte disturbances from the induced diuresis worsening hypokalemia, or sometimes swinging too far and causing a hyperchloremic metabolic acidosis.
So it's a calculated risk.
Absolutely.
Huh.
It should probably be reserved for situations where the risks of the severe alkalosis itself, like clearly failed ventilator weaning attempts, directly attributed to the alkalosis, seem to outweigh the known risks of the drug.
What if acetazolamide isn't enough or isn't appropriate? What's the next step for truly life-threatening alkalemia?
For truly severe life-threatening alkalemia, we're talking pH generally above 7.6, or maybe in patients with complete renal failure where urinary excretion is impossible. The ultimate intervention is acid infusion.
Giving acid directly.
Yes, specifically hydrochloric acid, HCl.
That sounds intense.
It is. It requires significant care and expertise. It must be given through a central venous catheter. It's far too irritating for peripheral veins. The dosing has to be meticulously calculated and individualized, using formulas based on body weight, the bicarbonate level, and the target correction. You typically start with a very cautious infusion rate, maybe 0.1 to 0.2 millimoles of H plus per kilogram per hour.
And monitoring must be tight.
Mandatory. Serial ABGs every few hours are essential to guide the infusion rate and prevent overcorrection, which could lead to a dangerous iatrogenic acidosis. This is strictly an ICU-level intervention.
Is there a safer alternative for patients with kidney failure?
Yes, thankfully. For patients with acute or chronic renal failure, dialysis using a low bicarbonate dialysate is often the safest and most effective way to rapidly correct severe alkalosis.
How does that work?
You deliberately set the bicarbonate concentration in the dialysis fluid, the dialysate, significantly lower than the patient's serum level, maybe around 25 to 28 millimoles per liter. This creates a steep concentration gradient across the dialysis membrane, pulling the excess bicarbonate out of the patient's blood and into the dialysate. It's efficient and avoids the risks of systemic acid infusion.
Okay, that covers the main treatment strategies. Let's connect this back to specific patient populations we see commonly in the hospital. Where does metabolic alkalosis become a major complicating factor?
Yeah, it's rarely an isolated issue, right? It's often intertwined with the patient's primary illness. We really need to consider these complex groups.
Let's start with COPD patients, especially those with chronic hypercapnia. You mentioned the ventilator weaning issue.
Yes, this group is perhaps one of the most vulnerable. For them, metabolic alkalosis isn't just an electrolyte issue. It's a direct threat to their respiratory status. It's a major therapeutic barrier.
Why is it so dangerous for them?
Because the compensatory hypoventilation that the alkalosis triggers directly suppresses their already tenuous respiratory drive. This worsens their baseline hypercapnia, potentially leading to catastrophic Pco₂ or retention. These are the patients who repeatedly fail spontaneous breathing trials, making liberation from the ventilator incredibly challenging.
So our treatment choices have to be very careful.
Extremely careful. The literature is quite clear on this. Loop diuretics, while often necessary for managing fluid overload or cor pulmonale in these patients, need to be used very judiciously. Higher diuretic use is associated with worse respiratory outcomes in COPD. More exacerbations, more hospitalizations likely mediated, at least in part, by generating and maintaining this detrimental metabolic alkalosis.
So minimize diuretics if possible. What if the alkalosis is already there and hindering weaning? Is that where acetazolamide comes in?
That's often when it gets used, yes. If impaired ventilator weaning seems directly related to the alkalotic suppression of respiratory drive, acetazolamide is employed. The goal is to quickly lower the pH, allow the Pco to rise slightly or normalize relative to drive, and hopefully restore enough ventilatory stimulus for successful weaning. But as we've hammered home, we have to approach this knowing the evidence for major outcome benefits like mortality or overall ventilator duration is weak, and there are risks. It's often used pragmatically while we simultaneously work hard to correct the underlying volume and chloride deficits that are maintaining the alkalosis.
Okay. What about patients with CHF or cirrhosis who get diuretic-induced alkalosis? That seems like a classic hospital medicine problem.
It's a very common and challenging scenario. These patients often require high doses of loop diuretics just to manage their profound volume overload, or ascites. But those very diuretics trigger intense neurohormonal activation, high renin, high angiotensin, leading to severe secondary hyperaldosteronism. And this hormonal storm relentlessly maintains the volume and chloride depletion, and therefore the alkalosis. It's a tough cycle.
How do we manage that? It sounds like you're stuck between needing the diuretic and the diuretic causing the problem.
It requires a more sophisticated, multi-pronged approach. often involving what's called sequential nephron blockade, plus aggressive electrolyte management. First, you have to try and minimize the loop diuretic dose to the absolute lowest level that still achieves the necessary fluid removal. You want to slow down the generation phase as much as possible.
Step 1, minimize the loop dose.
Step 2, aggressively replete chloride and potassium. Again, usually with high-dose oral or IV potassium chloride. This is crucial to give the kidney a chance to excrete bicarbonate.
And step 3, targeting the hormones.
Exactly. Target the source in the maintenance phase, which in these patients is often that high secondary hyperaldosteronism. Adding an aldosterone antagonist like spironolactone, is specifically recommended and very helpful here. It provides a blockade further down in the distal tubule, counteracting aldosterone's effect. This reduces the potassium and hydrogen loss that keeps generating new bicarbonate, effectively helping to break that vicious cycle driven by the underlying CHF or cirrhosis physiology.
Does untreated alkalosis in these specific patients have known consequences?
Yes, the clinical sequelae, of persistent uncorrected alkalosis in CHF and cirrhosis are significant. There was a study, the alkalotic study, which looked specifically at metabolic alkalosis in patients admitted with acute heart failure. It found that the presence and severity of metabolic alkalosis were associated with a higher risk of heart failure readmissions, worsened overall circulatory failure during the admission, and an increased risk of arrhythmias. So the alkalosis isn't just a passive marker of how much diuretic they got. It seems to be an active contributor to ongoing hemodynamic instability and poor outcomes in these vulnerable patients.
So the big take-home message across the board seems to be that recognizing and correcting metabolic alkalosis promptly isn't just about making the labs look better.
Absolutely. It's essential for mitigating real systemic risks, cardiac arrhythmias, neuromuscular problems like seizures or tetany, and especially respiratory failure, particularly in our critically ill population.
Okay, let's try to summarize the key points from this deep dive.
I think the central, really indispensable element in the workup is that spot urine chloride measurement. It's simple, readily available.
And it fundamentally directs therapy.
Precisely. When you interpret that value correctly, it dictates the entire therapeutic pathway.
So, chloride-responsive alkalosis, low urine chloride driven by volume and chloride loss.
Correct. And the fix is restoring those deficits.
Right.
Isotonic saline and high-dose potassium chloride. Give the kidney what it needs to work properly again.
Versus chloride-resistant alkalosis, high urine chloride, indicating an ongoing renal chloride leak due to hormonal or tubular issues.
Right. And here, saline is generally ineffective or harmful.
Yeah.
The treatment needs to be targeted. Mineralocorticoid blockers like spironolactone if aldosterone is the culprit, or specific management for underlying tubular defects.
And for the most severe life-threatening cases, pH over 7.55 or 7.60 or clear symptoms.
That's when we consider the more aggressive interventions like acetazolamide, especially in volume overload, or in extreme situations, carefully monitored hydrochloric acid infusion, or potentially low bicarbonate dialysis if the patient has renal failure. The priority there is rapid but controlled correction of the dangerous pH level.
So that brings us back to a really practical and maybe difficult question for clinicians listening.
Okay.
Given the evidence we discussed about acetazolamide, the known increase in adverse events versus that lack of a clear mortality benefit, particularly in trials looking at respiratory failure complicated by metabolic alkalosis, when do the theoretical benefits, like potentially improving ventilatory drive suppression, actually outweigh those known risks of the drug in practice?
That is the million-dollar question, isn't it? It's a tough bedside decision.
How do we best stratify those critically ill patients? You know, maybe the ones with really severe hypercapnia and a pH over 7.55, where the alkalosis seems to be the main barrier to weaning. How do we justify using acetazolamide in those specific cases? It really forces us to think about individualizing risk versus benefit for every complex patient where their acid-base status seems directly tied to their respiratory success or failure.
It does. That's the daily challenge, isn't it? Balancing the potential iatrogenic harm of our interventions against the clear harm of ongoing respiratory failure or severe alkalemia in the ICU. There's rarely an easy answer.
A perfect place to leave our listeners thinking. Thank you for joining us for this extensive look into metabolic alkalosis.